like this.
But just start recording. Yeah, first of all, start recording. Do you see it now? Just tell me.
Yes.
Okay, so I will start recording.
Okay, I will unmute my phone, my microphone.
Okay. Okay, so hello everyone once again, and I started recording this lecture, which the topic will be the musculo-skeletal imaging. I will make my screen bigger in order to show you with the mouse some of the findings that we'll discuss here. So first we will start with the main pathological processes which occurs into the bones. So maybe the most important and the most common one is the osteoporosis. Osteoporosis is a metabolic skeletal disease, a process which is defined as a reduction of bone mineral density below a limit, a normal value or a limit. And this process is essentially decreased by bone tissue per unit volume of bone. So you can see here in this schematical image the normal configuration of the bones, the trabecula, the inner structure of the bone here. You can see that there is an important reduction of the bone mineral density. Well, this process could be either localized or diffuse into the bones. Any identifiable cause and secondary type. So in primary osteoporosis, first of all is the so-called postmenopausal or senile osteoporosis. So you know that usually women after they're 50s and 60 years old, they start to lose some bone structures, so some bone tissue, and this makes their vertebrae a little bit more easily to be broken. And it usually affects the lumbar spine, but also the long bones. In the primary osteoporosis senile type 2, it occurs also in elderly. And there is proportionate loss of cortical and cancellous bones affecting the long bones. So there is also a third part which is called idiopathic or juvenile osteoporosis, but it's a rare condition. The secondary cause of osteoporosis or osteoporosis type 3 occurs due to a range of causes, including some endocrine diseases, some inflammatory processes. If you are taking any medications like steroids, for example, many other diseases and conditions. So let's take a look here what happens with the bones. So as I told you, first of affection of the lumbar spine. So we will observe on the radiograms a decreased bone density, and usually we will have vertebral osteoporosis which manifests like a penciling of the vertebra. This penciling is due to the loss of the inner trabecular bone structures. They are like the contours of the vertebra are like written with a pencil, and we call them also ghost vertebra. Sometimes it happens that we have compression fractures of the vertebra, and there is the general classification of the vertebral bodies according to the degree and the type of the deformity of the vertebra. It could be biconcave or convex, or so three main types of deformity in this general classification. You can take a look in the internet about it, and it's very, very nice presented. And there is also loss of trabecular proximal femoral area. Here, it happens in a later stage after the affection of the lumbar spine. In tubular bones, especially into the metacarpals, there will be some thickening of the cortex as well. So the most important study, which is quantitative study, is called DEXA scan, or dual energy X-ray absorptiometry scan. So we can measure the bone mineral density in grams per centimeter, and this gives you an absolute value. And this absolute value is probably, you remember the DEXA machine when I show you probably last year in our department. It gives you first of all one image like that of the vertebra, and after that this table with the percent and the percentage of the loss of the bone mineral density. So what is the basis of this dual X-ray absorptiometry? So you have measurement of the bone mineral density, and if you have a normal T-score up to -1, you don't have any osteoporosis. Osteoporosis is when the calculated T-score into the vertebrae is less than 2.5. And these values between -1 and -2.5 refers to osteopenia. The opposite process of osteosclerosis is of osteoporosis is called osteosclerosis. This is in osteosclerosis the bones appears very dense. We can have either bones dense bones islands or anostosis, or some bone scars, or even some focal periapical osteopetrosis. So in that disorder, we have hardening of the bones and elevation into the bone density. You can see here that you have, for example, appearance of a very dense structure into the right film. And plain radiographs are a very valuable tool for detecting and classifying these osteosclerotic disorders. So different examples of osteosclerosis affecting different parts of the bones into the human body. You can see, first of all, here the lower vertebra of the lumbar spine, the calcaneus, the tibia, so different receiver into the skull. So in osteolysis, we have a progressive destruction of the bones, of the bone tissue, and in this process, the bones lose minerals, mainly calcium, and they get softened, they degenerate, and they become weaker. So fractures can occur more easily. The most common type of osteolysis, in which is generally unrelated one to the other, is the distal clavicular osteolysis, periprosthetic osteolysis, and acrosteolysis, which is very rare. So those are some examples of osteolysis. You can see here the three different ones. The first one was the just a second, but we don't have the annotations. Okay, but this is the localized, and this is the more diffuse form of osteolysis. So different other examples of osteolysis. I will probably move to full screen, because if we are in full screen, we will see some remarks that are not usually visualized when we are not using the full screen. So I'm changing a little bit for a full screen. If you have, if you need again to show you with the mouse, I will reopen the normal mode. Okay. So in this osteolysis, again, I see a big area of the skull, which refers to loss of mineral density. Here, for example, we have different locations of some osteolytic processes, like aneurysmal bone cyst, for example, location of the tibia and the fibula, or location of into the calcaneus. So we have some cystic masses with some fluid levels with different signal intensity in these different structures on those MRI images. Okay, osteonecrosis. Osteonecrosis affects mainly, I don't know why this is in Bulgarian here. Okay, so only this slide is in Bulgarian. I'm sorry about that. Anyway, I will keep it. I will move to the next one. So in osteonecrosis, we call it also vascular necrosis, or aseptic necrosis of the, or even ischemic bone necrosis. This is a disease which results in death of bone cells, and usually it could occur even in young patients in their 40s, for example. And you will observe on radiograms only the late changes of the disease, but the very first findings will be localized on MRI, because MRI is very subtle changes in bone in edema. Bone edema can be both hips, and you can see that in the left hip there is loss of deformity of the head, of the femoral head, and this is a typical example of osteonecrosis with deformation of the head. So those are some other locations of vascular necrosis. Here the process is bilateral on the hips. This is a T2 sequence with fat saturation, or PD, proton density image. This is location of both condyles of the femur, the lateral and the medial condyles, and again one area with irregularities and loss of changes in the signal intensity due to this necrosis, which is located in the head of the humerus. So we are moving to the next pathological process, which is very important. It's called periostosis. And in periostosis, we have a deposition of the periosteal bone, which manifests by growth of some periostomas. So something is growing into the periosteum. And the etiology could be either inflammatory or reactive due to some tumors, for example. So there are different patterns, different types of periostosis that we will discuss on the next slices. The first one is called single layer or laminar, one lamina periosteal reaction. In this, you can see here the one lamina standing parallel to the periosteum of the bone. This is a uniformly dense, single thin layer of new bone, which is about 1 millimeter from the cortical surface. You see it here probably now. And it denotes an acute or subacute pathological process. Another type of periosteal reaction, which is in fact refers to a malignant process, is the so-called hair on the end side, or spiculated, or even sunburst appearance, like the sun rays, for example. This is radiological appearance of a diploic space of the skull vault, which results from a thickening of the trabecula of the diploic space, and which expands all over the skin, towards the skins, and this trabecular are perpendicular in orientation. They intersperse by radiolucent marrow hyperplasia along to the skull vault. So this is the hair on the end sign, which is very common in some malignant processes, and the sunburst appearance as well. Another sunburst appearance of the long bone of the forearm here, and on the lower image you have a dantel-like periostosis, like a dantel. So this is also a sign of a malignant type of osteoporosis. Probably the most severe or the most malignant type of periosteal reaction is the so-called Codman triangle periosteal reaction. This is a type of periosteal reaction which is seen with aggressive bone lesions. The periosteum does not have any time to ossify with shells of a new bone formation. You see this triangle here, and we call it Codman triangle. So this is the mechanism of how this process happens. Probably one of the more benign type of periostosis, we are not afraid when we saw it in some of the patients, is the so-called solid periosteal pattern, which can be evolved from a single layer to multi-layer periosteal reaction, and this forms a solid layer of richer new bone, which is just adjacent to the cortex. And this is a long-standing process, so it takes many months and years to happen, the solid periostosis. In some types of periostosis, we have a combination with formation of osteophytes, like in this so-called spore calcaneae of the calcaneus, osteophyte in the lower pole of the calcaneus, or those multiple osteophytes in the anterior parts of the vertebra, in the lumbar spine. Another process is called osteodystrophy. This is any dystrophy of the bone, and this defective bone development is usually attributable to a renal disease and some disturbances in calcium and phosphor metabolism. So one very common form is the so-called renal osteodystrophy. Have some deformities of the bones with some osteolytic, osteodystrophic changes. So in chronic kidney disease, we can have some disappearance of the lumbar vertebra like a zebra. So they are very typical for these conditions. You can see that this tibia and fibula are not so narrow. They are a little bit curved, and in this disease is called osteogenesis imperfecta. In osteopetrosis, or literally very stone bone, so very dense, very marble bones, we also call it really marble bone disease or Albert-Schonberg disease. This is an extremely rare inherited disorder whereby the bones became hardened, they became dense, and in contrast to the most prevalent conditions like osteoporosis. So you can see, for example, in this child, very, very dense bones. Even the pelvis appears very bright on the radiograms. This condition, when the bones are very, very dense, marble, we call it osteopetrosis. What about those images? It looks like eaten molded appearance of the myeloma, multiple spots, multiple like small holes into the most typical location is the skull vault. Okay, so this was till now the main pathological process that we should be able to identify in order to describe the findings and to move further on. So now I will familiarize you with the most common locations of articulations or joints, which are usually object of magnetic resonance. We will not speak here too much about the X-rays, neither about the CT, because CT is in the musculo-skeletal system is used mainly for fractures. We will move later on for the CT. Okay, so the shoulder, the main indication for examining of the shoulder are chronic pain, shoulder instability, bone lesions, and prior prosthesis. And the algorithm always starts with conventional X-rays, eventually ultrasound and MRI and MR arthrography. Well, here we have an example of displacement of the brachii tendon. Usually it should be located here. And there is also some liquid content into the sulcus of the biceps brachii tendon. This sulcus is called sulcus intercondylaris. And once we have a displacement, this could result to a rupture of the tendon. And we see in this example a very nice image of a tendon could not be visualized in his proper position, right into the fossa, into the groove of the tendon. And the proximal end of the ruptured tendon is located close to the glenoid labrum. This is the glenoid labrum here. So this is another shoulder joint here. We call it glenoid labrum tear because we have a rupture of part of the anterior labrum. So these tears can be located either above in the superior or below in the inferior or middle part of the glenoid socket. So in superior labrum rupture, we call it also a slap lesion, superior labrum anterior to posterior, anterior to posterior. So this is a tear of the rim above the middle of the socket, and it may also involve into the biceps tendon. So when this part is ruptured, this is a superior labrum rupture. In the so-called shoulder impingement or rotator cuff tendinitis, this is one of the most common sources of pain in the shoulder. And the pain results mainly from tendinitis when the tendons are irritated or damaged, from bursitis when the burrs are filled with liquid, and from impingement when you try to raise your arm to the shoulder height. The space between the chromion and the rotator cuff narrows. This is this space here. So the chromion can rub against, or we call it impinge on, the tendon of the bursa, this tendon, and this causes irritation and severe pain. Once we can observe a partial rotator cuff rupture, the rotator cuff is mainly is mainly formed by the infraspinatus muscles. In this condition, a condition that mimics this partial rotator cuff rupture is the frozen shoulder. So you can hear a schematic. See here this schematic, a nice view of a partial tear and complete tear of the tendon. In complete rotator cuff rupture, we will have stitching the tendon back of its original site of the humerus. So you see that here is completely ruptured. So all those tears are very easy to be diagnosed with MRI. And the hyperintense signal areas within the tendon, the tendon should appear as dark, like this tendon, like the biceps brachii tendon. So they appear so bright on T2 fast suppressed images, and they dance from the articular to the bursal space, and the presence of tendon filled with water is the most common sign of rotator cuff tear. So this is an example of avascular necrosis of the head of the humerus. I already showed you a few examples of avascular necrosis, and we can see here a heterogeneous aspect due to the bone marrow changes. So first we will have the bone marrow change, we will have the deformity of avascular necrosis. The change in the form and shape of the humeral head appears later, and all those irregularities of the margins can be clearly visualized on MRI. So the wrist joint, the main indications are again traumatic changes, avascular necrosis, cystic lesions, and carpal canal syndrome. And the algorithm is always perform MRI following X-ray examination, and this MRI can replace arthrography. So this is a Kim-Bjork disease. In Kim-Bjork disease, we will have osteonecrosis involving the lunate bone. It is often referred to lunatomalacia. And the contour and the shape are changed, the duration of the bone is changed, and there will be joint effusion. There is a partial rupture of the ligamentum sphenolunatum. Just a second, I will make just a very short interruption. I will pause recording and I'm coming back once again. След малко ще извънна, че съм на лекция, записвам със студентите. Добре сега, следата вече. Ама добре ли си? Колко е сега? Добре. Ставай се, разхождай се, чуваме след час. Okay, let's resume recording. I'm sorry about this interruption. I think we can continue right now. And in partial rupture of the ligamentum sphenolunatum, we will have this tear here, ligament. Another example of rupture of the ligamentum lunotriquetrum between the lunate and the triquetral bone will appear with this low signal intensity tear in the ligament. So here the indication for performing examination of the knee joint are mainly from meniscal and ligament injuries of the joint, synovial lesions, and cartilaginous lesions. And this is one schematic algorithm how we can perform these different modalities. And in meniscal tears, we will have the grading from normal meniscus to degeneration of the meniscus, which will present as a linear hyperintensity lesions, linear, and not with oblique shape and form. And in C will be partial meniscal tear, and in D will be complete tear, which will be adjacent or close to the articular surface. So here will be the femur, here will be the tibia. And this is one complete tear of the meniscus. This is the posterior horn of the medial meniscus, which appears hypodense, intense area with a hyperintense lesion. This linear high signal intensity lesion in the posterior horn corresponds to the lesion. Sometimes we will have some cartilaginous tear. You can see that the cartilage, which is just communicating between the femur and the tibia, is very thick, very thin with some high signal intensity of this cartilage. The anterior cruciate ligament usually appears as a low signal intensity, well delineated lesion. This is the normal appearance of this ligament, which usually ruptures after main traumas like sport trauma or some other. And here is the posterior cruciate ligament, which is a normal finding in this example with the curves. This presents as a curved structure with low signal intensity. But here you can observe the anterior cruciate ligament rupture. I'm sorry, there are a lot of mistakes because I did it in the last moment, and it should be A here. The anterior cruciate ligament is missing, and in the place of this ligament we see some irregular contours and high signal intensity, and we didn't see the continuity of this ligament. The posterior ligament ruptures very rare. In severe trauma will appear as a change in the form and shape of the ligament with increased signal intensity. Here we have a rupture of the patellar ligament, the ligament which connects the lower part of the patella to the tuberositas tibiae of the tibia. And since this here in this image it's ruptured, and here we have the increase of the signal intensity with normal patellar ligament, but this retropatellar fat pad, or we call it also Hoffa space, is with high signal intensity. Sometimes in rupture of the patella, we have the patellar ligament, we have superior displacement of the patella in upper position. This is a normal appearance of the patella in axial slice with a normal signal intensity of both patella and cartilage of the patella, and normal thickness of the cartilage. In osteochondritis of the patella, we will have a hyperintense defect of the patellar cartilage. You can see it here. It's shown with the arrows. And also hyperintense lesions in the patella itself on T2 and PD sequences due to the bone marrow edema. We're moving to the hip joints. Hip joints, we will have mainly osteonecrosis, algodystrophy, chronic pain with unclear etiology, traumatic changes, and tumors as main indications. And we will perform MRI after CT, and the MRI will replace the CT. The CT will be used only for fractures. So here, this is a aseptic necrosis of the hip. In this aseptic necrosis, I will show another example. We will have joint effusion. We will have presence of potentially osteochondral fragments here. And you should know that MRI is the most sensitive modality with sensitivity of up to 100% and even specificity up to 100%. So the rim sign is very typical. This is the rim sign, the hypointensity, which makes the border between the affected bone in the vital, the non-affected bone. This delineates the subchondral fracture. The ankle joint, the main indication is this abbreviation OCD, means osteochondritis dissecans. AVEN is the avascular necrosis structure. This is an example of osteochondritis dissecans of the talus. And we can either have a bone fragments in late phases, but in the very beginning, there are 4 stages of the disease. We will observe hypointense rheum at the periphery. So this could be considered as a stage 2 of osteochondritis dissecans of the talus without any fragment. The same patient in the lateral projection or sagittal projection, we see this lesion with high intensity, hyperintense lesion, which is located at the roof of the talus in a sagittal PD fat saturation image or sequence. Here we have a patient with partial rupture of the tendon of the tibialis anterior muscle. This is again a sagittal plane. We observe thickening of the tendon, which is with heterogeneous signal intensity. The partial rupture of the same tendon on axial slice. It looks like enlarged the diameter of the tendon. You see this tendon, how large it is. And the tendon is with inhomogeneous signal that it's not so dark like it should be, but there are some hyper-intense or white areas in the middle of the tendon. So the main, we are moving to the bone tumors, and we'll mainly discuss the role of the magnetic resonance imaging and usually in the staging of bone tumors. So if I want to give you the outline of this part of the lecture, we will have a short introduction, then we will see the different imaging techniques or modalities, saying a few words about the conventional X-rays, then how can we stage the bone tumors, and what is exactly the role of this MRI imaging, and a very brief summary at the end. So here we have as an introduction about the bone tumors. We will have that the primary bone tumors can state that they're relatively uncommon, and they should be best managed at the specialized centers, not in every hospital, in every department, because we need to have a multidisciplinary team approach. And in this team, we have not only radiologists for the diagnosis or pathologists for histopathological verification and diagnosis, but we should have orthopedic surgeons and oncologists. And the main imaging techniques are the same as you already know, every one of you. The radiography, we can perform imaging guided biopsy either under ultrasound control or under CT control. Of course, the CT is very useful in some occasions, not only for trauma, but in some tumors. The bone scintigraphy and the angiography can be used in some tumors. We will discuss the role of those imaging modality. Probably the most important, the most appropriate method will be the MRI imaging. So when should we perform radiography? Radiography is considered as an initial imaging technique for evaluation of suspected bone tumors. And it has a poor diagnostic value for soft tissues and very small bone medullary lesions. We will miss them, we will not see them. So in radiography, we have the so-called don't touch lesions. So some benign findings, they don't need to be to perform them biopsies, or they don't need to be investigated further on by some other modalities. And systematic analysis of the skeletal tumors should be performed as well on radiography, and we can take on radiography are there any signs for aggressive or non-aggressive tumor. So here we have some few examples of so-called don't touch lesions, like the bone islands here in the wrist, the non-ossifying fibroma, or the presence of exostosis. This is like supplementary bone in the metatarsal, second metacarpal bone here. And this is an example of humeral pseudo tumor, but in fact, if we perform the CT, it looks like it looks equal on both sides, so there is no tumor at all, just a mimicker. These findings, you can either tell a cyst, a bone cyst, because it's radiolucent, or a pseudo tumor. But once you perform the CT, you see that everything is normal here. So sometimes you are able to make the difference between aggressive and non-aggressive tumors, like enchondroma is non-aggressive tumor, for example, in this image here. And then if we perform an image-guided biopsy, this should be done by the most qualified person, because there's a lot of risks in those biopsies. It's best to be done at a specialized center, and this biopsy under imaging control is much cheaper and safer than the open biopsy performed by the surgeons. So we do it after staging is completed. So we need CT and MRI for staging. After that, we move to biopsy. And we can do it either under radiology or fluoroscopic control, or under CT guidance. Under CT guidance, you can see here one lesion in the arcus of in the pedicle of this lumbar vertebra. And the patient, when it lies on his belly on the table, we have a dorsal approach, and we insert a needle inside of this lesion, and this is a biopsy of L1 pars interosteoblastoma. So the CT, when we perform CT, the main application is the detailed evaluation of a local disease. If we have some subtle lesions, or if we have a complex shaped bones, and for optimal assessment if there are any pulmonary metastases, because many of these bone tumors can give you pulmonary metastases. That's why you will perform a total CT scan of thorax, abdomen, and pelvis, of the total body. Well, this is an example of eosinophilic granuloma of the ileum, and this eosinophilic granuloma is best visualized on CT. You see that here in the ileum, you are not able to identify where exactly you are seeing this lesion. But if you perform a CT, you will say that this is an osteolytic lesion. And the biopsy proven eosinophilic granuloma. So CT is performed for lung metastasis. You can see several spots in patients, different patients with osteosarcoma, with bone osteosarcoma. They present with bone metastasis. Then bone scintigraphy can provide you an overview of the entire skeleton, because we can perform this examination in a routine staging for the bone tumors, and also for screening for metastasis or for lesion multiplicity. So you will discuss it with the professor of nuclear medicine, but just to let you know, those are few images of nuclear medicine study of bone scintigraphy. One is in a young tumor with location in the upper humerus, and the other one is unfortunately widespread of bone metastasis affecting all the bones. All these dark spots represents metastasis in the human skeleton. In angiography, the diagnostic role has been largely replaced by contrast CT and contrast MRI, but there can be still a selective role in defining vascular relationship. And we can use this method for preoperative embolization of some of the tumors. For example, you can see here a CT image of a big osteolytic lesion with a soft tissue component, the respective MRI images, and the pre-embolization angiogram in case of giant cell tumor affecting the pelvis. This is a giant cell tumor. So moving to the best important modality, the most important and most appropriate modality for assessment of the tumors. This is the MRI. The big advantage is that you can perform this modality by using multi-planar imaging capability, so you can select any desired plan for scanning your patients. The method is very sensitive for the medullary lesions, and you have superior soft tissue contrast and extent. You can see some neurovascular bundles, some muscles or fascia, and there are no beam hardening artifacts and no ionizing radiation hazard. The limitation of the method, it's poor for calcifications. You know already that calcifications and calcium in general are not seen on MRI, but are better visualized on CT. And it's poor for in the cortex. In fact, we have more calcium than in other parts of the bones. And we need to correlate with other imaging studies. Always correlate your findings between CT and MRI. So compare with the other imaging modalities. The main principle of the method is we obtain images in two orthogonal planes, minimum two, better it will be three, sagittal, axial, or coronal plane. And usually we use whole sequences, T1 and T2 in the same plane, and minimum for meaningful comparison and for tissue characterization. The long bone tumors can be scanned. The aim is to have it in the true orthogonal planes, in axial plane, to see the relation to the cortex, the relation to the muscles, the neurovascular bundles, and the soft tissue. The coronal and the sagittal plane are very useful for longitudinal extent of the lesion, for physical and joint involvement by the tumors. The long bone tumors are scanned in coronal plane for tumors extending lateral and medial to the lateral and medial projection. In the sagittal for tumors which extends in the anterior and posterior direction, and the third plane for complex joints, which has two and more articulations like the ankle, the shoulder. Those are the most complex joints. So the multiplanar imaging facilitates our jobs, and we can scan in different places like the axial plane, the coronal, and the sagittal plane here in this giant cell tumor with some aneurysmal bone cyst component inside. So we used contrast for characterization of the bone tumors, because this will give us additional information. This will delineate us the necrosis from the active tumor, and also make a delineation between the solid and the cystic lesion. And the contrast was injected in T1 sequence, and we need fat suppression for better visualization. So if we suppress the fat, everything will be dark, and all the tumors, which enhances the contrast, will appear as a bright or hyper intense in T1 post-contrast. Other factors to consider is the choice of the coil. So should we use the body coil or the coil, or which coil? The technician, it's a question to the technician. He'll choose the appropriate coil for examination. The slice thickness should be as low as possible, of course, but this is a compromise with the image quality. The interslice gap, and it also depends on the image size and the location of the tumor process. So our aim is to add the planning of the surgeon, to facilitate the surgeon, because we can delineate the margins for the surgical resection. And this is facilitated by the interinstitutional and interdisciplinary communication. So the discussions between surgeons, oncologists, and radiologists. So now we will speak a little bit about the tumor staging, and the current system that we are using is the Eniking system. This is the most widely used for staging of bone tumors, and there are some criteria that should be fulfilled. This system is dealing with interrelationship of the grade, the site or the location, and the presence or not of metastasis of the tumors. So the grade is indication of the biological aggressiveness. It could be either benign G0, low grade G1, high grade G2. And there should be also clinical, histological, and even radiographical evaluation. So let's take a look of two tumors here. One is this one is osteosarcoma, and this one is a fibrous dysplasia. You see that we don't have any, the tumors are very well defined, and the tumor does not extend from the contours of the normal contours of the bone. And here the bone is really very, very big, and the tumor extends outside of the limits of the normal bone in osteosarcoma. So the site is important in the endocrine system because it depends on whether lesion is confined to its anatomical compartment by natural barriers like the cortex or cartilage, like in the first example on the previous one. Is it intracompartmental, T1, or extracompartmental? So this one is intracompartmental, not extend to the normal contours of the femoral neck, and here it's most aggressive and it extends in outside of the anatomical compartment. So the presence or not of metastasis is very important for the future of the patient prognostic as a prognostic tool. If we have no metastasis, M0 in the endocrine system, and if there is any metastasis, M1. Metastasis also includes regional lymph nodes metastasis. So this endocrine system will be like this: benign, low, and high for the grade, intracompartmental and extracompartmental for the site, and presence or not of metastasis, even regional or distant metastasis. And this is the schematical, the schema of these different stages from 1A to 3. So sometimes we should correlate the tumor with the excision of the margins, and in T1A we have white excision, in white B we can white excision, but usually amputation of the limb. 2A is reserved for radical excision, usually amputation, and white excision plus effective adjuvant radiotherapy. And 2B or 3 is for palliative resection, could not be removed totally. So the description applies only this endocrine system only for mesenchymal tumors. It does not apply for the non-mesenchymal tumors, like for example Ewing sarcoma, Lyme, or to have some, in this condition, you should add some bone marrow aspiration biopsy. And the major technique, again, I will emphasize on this, is the MRI, because it's the ideal technique for local staging and for treatment planning. So the bone tumors, there can be non-specific sometimes, so not reliable for making histological diagnosis of the tumor type. And mostly they appear as a T1 iso-intense mass, and T2 they appears with high signal intensity or hyperintense, and they have heterogeneous aspect with the presence of areas of mineralization, necrosis, and hemorrhage. Let's review a few examples. This is a hemorrhage in aneurysmal bone cyst with pathological fracture here in the humerus. This aneurysmal bone cyst, you can observe the cystic content with the blood and liquid formation of a level, liquid level into this area. And the local staging, of course, again, staging method of choice for tumors will be MRI for staging, because the MRI can give us a precise preoperative delineation and planning of the surgical treatment. We will use T1 and T2 sequences mainly, but also perfusion and diffusion techniques as well. We should consider processes located within or outside the bone. What is the relation to the muscle compartment, to the neurovascular bundles? What about the growth plate and the joint? And is there any important extra or soft tissue compartment? This is an example of a simple bone cyst. You see a cystic lesion with thick, thin walls with regular margins, with high signal intensity on T2 imaging and low signal intensity on T1. But what about this example? This is a very aggressive tumor. There is discontinuity of the periosteum here. In the epiphysis of this bone, we have important soft tissue involvement. But you can see that the tumor is invading the muscles, the soft tissue, and is spreading outside of the normal bone. So this is a pathological specimen of this osteosarcoma with epiphyseal and soft tissue involvement. And again, another example of osteosarcoma with central necrosis, cortical invasion, and periosteal involvement. Example here. And tibial osteosarcoma near a neurovascular involvement. Again, the tumor is located close to the neurovascular bundle. These are the arteries and the nerve, but the tumor fortunately doesn't encompass these structures, so there are some possibility for rejection, even it could be a to the tibia. So another example, osteosarcoma of the fibular head with extensive soft tissue involvement. You can see the huge soft tissue mass, and here the disruption of the cortex of the tibia. The fibula is not visualized; it's probably completely distracted. And they make some biopsy here, and it takes this is the sample, probably an open biopsy. And MRI is also plays an important role for treatment, because we can say with MRI, is there any limb salvage surgery? What about the margins of the resection? Can plan radiation therapy. We can assess the response of chemotherapy, and we can follow up our treated patients with treated tumors. This is a pathological fracture in osteosarcoma, and the patient has been amputated here. You see, this tumor is very aggressive, and after the control MRI with the amputation of his left lower limb. In case of a Ewing sarcoma, like this example, we have a limb salvage, but the surgeons, they place a composite allograft here instead of his own femur. This is the allograft. This is an example of another aggressive tumor which responds very well to chemotherapy, and this is a lymphoma of the humeral head. And you see the image before and post and after chemotherapy, the follow-up 4 weeks later. The tumor is, I'd say, treated, and does not looks like so aggressive like in the very beginning. This is an osteosarcoma, pre and post chemotherapy. Eventually, this patient will have limb salvage, but we will not pretty sure, because this is the typical Codman triangle. You remember from this type of malignant periosteal reaction called the Codman triangle in the beginning of the lecture. This is indicative for malignancy. In this 10 weeks later on, we have this image here, and probably he will not lose his leg. This is an example of osteosarcoma. You can see that the tumor is spreading into the muscles around, and this is the MRI image of the sunburst of periosteal reaction with a solid mass with the soft tissue component, extraossal component of this tumor. I will familiarize you with few other conditions affecting that are some findings that are very common in our everyday practice. For example, the hemangiomas, which appear as vascular structures with high signal intensity. They are usually rounded, and they are located into the vertebral bodies. So you see here one axial T1, sagittal T1, a sagittal T2 image with some rounded hyperintense lesions inside, corresponding to a hemangioma, which is a benign finding. This is not a benign finding here, because those are metastases from breast carcinoma. Metastasis appears as a lesion with low signal intensity on T1 here in the vertebra, but also in the pedicule. This is the axial T1, and with high signal intensity on T2 sequences. Few words about disc herniation. In this herniation, we will have part of the disc which extrudes dorsally, and when we have this extrusion, this is at the level of L4, L5. It fulfills the entire spinal canal, so we will have a stenospinal stenosis in this example. And this is a very, very important discal hernia at the level of L4, L5. Probably this is also a very small hernia at the level of L3, L4 in this example. And this another L5, S1 discal hernia. We have also narrowing of the discal space. There is a risk of fragmentation. If you have a fragment of a discal hernia, the patient should be operated. It should be removed from the spinal canal. We will finish with some infectious diseases affecting the spine. One of the most important infections is spondylolisthesis. This spondylolisthesis could be either pyogenic or tuberculous discitis. It usually occurs in elderly patients. And in these examples, you see at the level of the L5S1, one big segmental involvement by the process with presence of poorly defined paravertebral mass here in the soft tissues, with early intervertebral disc involvement and homogeneous enhancement after contrast. Here is the post-contrast study. So with alternation of the signal intensity of the affected bodies, so the adjacent affected bodies are taking the contrast. So this spondylodiscitis always occurs at one level. You will not see it in multiple discs. Only one disc is affected usually. Okay, I think we will start with that. For summary, I can say you that the imaging is a important role in staging and management of the primary bone tumors. Especially, we will use MRI for that. But all the modalities are complementary. So we will insist on radiographs for initial investigation. We can rely to CT and bone scintigraphy, and mainly for local staging, we will rely on MRI imaging. So it's important to classify the tumors with the Anakin staging system, and the interrelation of grade, site, and metastasis with different imaging modality is the key for the proper diagnosis. So I would like to thank you for your attention, for participating, and we will meet either next week or a little bit later. It depends on the professors of radiotherapy and nuclear medicine. Okay, so I will stop for